one and all. This is Dr. Rajeshri Bhar from the medical team of USB. On behalf of my organization, I welcome you all to today's Indo Global Talk Show, a platform where we can connect with the international experts and benefit from their vast knowledge and experience in the area of metabolic health. As we all are aware of, diabetes is a major global health concern affecting millions of people worldwide, and millions of deaths are being directly attributed to diabetes each year. The main agenda of today's Indo Global Talk Show is to understand the practice around SGLT2 inhibitors, its safety and efficacy in metabolic health, how combination therapy works, and its applicability in the newer era of type 2 diabetes mellitus management as being viewed by different specialties globally and in Indian setting. There has been a revolution in our understanding of SGLT2 inhibitors. Central to this revolution is the concept that the metabolic benefits of SGLT2 inhibitors are independent of the glucose lowering effects of these drugs. Given this increasing prevalence of obesity, type 2 diabetes, heart failure, and CKD, SGLT2 inhibitors have potential benefits for considerable proportion of the population. In fact, as per the recent ESC recommendation just updated 2 days back, SGLT2 inhibitors are recommended in patients with symptomatic heart failure and a mildly reduced ejection fraction and symptomatic heart failure preserved ejection fraction to reduce the risk of heart failure hospitalization or CV death. To take us through the fascinating aspects of SGLT2 inhibitors in metabolic health, we have with us eminent experts today. It is my proud honor and privilege to introduce the experts. Dr. Antonio, who is a research consultant in Italian Ministry of Health, IRCCS Multimedica Milan, Italy. He is an adjunct professor of internal medicine at the Luigi Vanvitelli University at Naples, Italy. Professor has been appointed by IDF as co-chairman for the development of the 2023 guideline for the management of type 2 diabetes in different settings as a chairman for 2024 IDF World Congress. Currently, he is the chairman of Diabetes and Cardiovascular Disease Study Group of ESAD. Professor is a senior advisor to the board of IDF Europe for year 23 and 24. Professor had been widely published in diabetes with over 550 original papers and several book chapters. His current index is H-index is 122 for Google Scholar and 100 for Scopus. He also served as an associate editor of Diabetes Care from 2003 to 2011 and an associate editor of Diabetic Medicine from 2005 to 2016. From July 1st, 2016, he has been appointed as an editor-in-chief of Diabetes Research and Clinical Practice, the official IDF journal. Welcome to you, sir. Now let me introduce you to our today's moderator, Dr. Sunil Sathe from Pune. He is a gold medalist in MD Medicine. He was awarded by the ET as the Inspiring Cardiologist of India in the year 2020. His special interests are in interventional cardiology, electrophysiology, and teaching. Lastly, in the panel, we have with us Dr. T. Dinakaran from Chennai. He is an MD in medicine, a member of National Academy of Medical Science, and DM in nephrology. Currently, he is the director and chief nephrologist of Madurai. He is the director of Kidney Center and Transplantation Research Institute, Madurai. His keen interests are in diabetic nephropathy, CKD, hypertension therapy, and preventing CKD progression. Now, going ahead with the session, today's session, now let's deep dive a little into the subject of metabolic health. I would like to hand over the session to our today's moderator, Dr. Sunil Sathe. Over to you, sir.
Thank you, Dr. Rajeshri. Welcome, Professor Antonio and Dr. Dinakaran, and all the audience. Today we are going to have a very interesting session with SGLT2. The advent of SGLT2 inhibitors has really revolutionized the management in various subsets, most importantly being heart failure, diabetes, and prevention of coronary artery disease, cardiovascular diseases. To discuss this, we are going to have none other than Professor Antonio, and he is going to speak to us and give us the insights on role of SGLT2 inhibitors in metabolic health. So without wasting time, I hand over the session to Professor Antonio. Professor Antonio, please.
Thank you very much for the introduction, the kind introduction, and for the invitation to join this very intriguing and interesting meeting, but also the opportunity to share with my Indian colleagues some aspect of SGLT2 use alone or in combination, which probably are not completely well known, and I will explain why during my presentation. First of all, I think we need a little bit of a background, meaning that when we look at particularly at the more important comorbidities in type 2 diabetes, it's clear from the data that the combination of cardio and renal disease is the most frequent and the first comorbidity in these patients. But what is really worrying is that this combination also is the most dangerous combination in terms of increase the mortality risk in people with the type 2 diabetes. So to target cardiovascular disease, to target kidney disease, particularly when they are together, because there is a strong interaction between the kidney and the heart, is very, very relevant to preserve people with diabetes from serious complications. When we look at optimal management of diabetes, clearly there are several aspects of the correct management of diabetes. One really important is the glycemic control. Of course, by definition, diabetes is characterized by high glucose. So glycemic control is very important. We know that also hyperglycemia plays an very important role in microangiopathy, but also in macroangiopathy, meaning also in cardiovascular complications. So glycemic control is, of course, a key strategy to prevent complications. On the other hand, a huge percent of people with diabetes are usually overweight or obese. So there is a need for weight management, particularly to get a reduction and possibly to keep the weight stable after reduction. One more important aspect is, of course, we try to avoid the appearance of comorbidities, but if we have to manage, and much better if we do all the best in order to treat the comorbidities, and of course, also to try to prevent how we will see soon. But clearly, all these aspects must be done trying to avoid hypoglycemia, which is a very serious side effect of any treatment of diabetes. What about glycemic control? I think that whether we want to speak about SGLT2 inhibitors, we have a lot of data, particularly related to dapagliflozin. You see here that there is just a very short synthesis of some of the trials which were developed for the approval of DAPA for use in medicine, for use for the treatment of type 2 diabetes. And we cannot forget that DAPA originally was coming out to reduce hyperglycemia in diabetes. What we found out later is very important, but at the beginning, dapagliflozin emerged as a very good hypoglycemic agent. And you see from this data, from the data of all these trials, that alone or in combination with the other oral agents, DAPA works very well in reducing A1C. However, today, when we speak about the glycemic control, the concept is completely different and is not related only to the control or the reduction of A1C. This topic should need a very long explanation, but just to synthesize that we have evidence that the perfect modern management of hyperglycemia today means not only to control A1C and fasting blood glucose, but also to try to have as much possible in the range for much longer time in the range of the glycemia to avoid the short and long-term glucose variability, to reduce postprandial hyperglycemia, both at 1 hour and 2 hours. And finally, all this should be got used to avoiding hypoglycemia. And if hypoglycemia is produced, we must pay attention how we recover from hypoglycemia, trying to avoid the induction of hyperglycemia. There is a huge literature behind, and this is well accepted concept today. Why I'm showing this? Because clearly, when we speak about controlling hyperglycemia, it's not only important to reduce A1C. And of course, we have evidence. I just showed some trials showing that dapagliflozin effectively reduce A1C, not only, but also reduce fast blood glucose. So there is no doubt that is a good hypoglycemic agent. But what about the new aspect of glycemic control today and dapagliflozin? If we look at postprandial hyperglycemia, we see that dapagliflozin significantly reduce postprandial hyperglycemia both at 1 hour and at 2 hours. Is also able, of course, to avoid hypoglycemia. It's very well known that the SGLT2 inhibitors are accompanied by a very low risk of hypoglycemia. And finally, there is also a significant reduction of glucose variability. So in other words, we have strong evidence that dapagliflozin is able to face all the aspects of glycemic control which today are considered. Of course, also to time range. What about weight management? I just told you that it's very important to get a reduction of the weight. Well, the dapagliflozin has shown that in any trial that it can reduce significantly the body weight in people treated. So we have also this extra effect when we use dapagliflozin in people with diabetes who are overweight or obese. But of course, one of the key aspects of diabetes management is the management of comorbidities. We have the pivotal trial about dapagliflozin, which is DECLARE. This was the first trial which was required by FDA. I think that you know very well the story why these trials were required by FDA. I did not go in this, but I would like to underline something. If you look at the percent of people with not a previous cardiovascular event, you can see that in the DECLARE trial compared to CANVAS and EMPA-REG outcome, meaning the other two trials using canagliflozin or empagliflozin, in the DECLARE, we had the majority of the people without a previous cardiovascular event. Of course, people are high risk for cardiovascular event, but without a previous cardiovascular events, which means at the end of the day, there's more than 50% of the people of DECLARE could be considered in primary prevention. And so it's particularly relevant at the well-known outcome of this study, where it was clearly shown that the dapagliflozin was able to reduce the risk for heart failure hospitalization, and also for the combination of the heart failure hospitalization and total mortality. But I think that this very recent paper published a few months ago is also very intriguing. It is a post-hoc analysis of the DECLARE trial, and is able to show that the dapagliflozin was able to reduce the risk of a total non-elective hospitalization for any cause in people with type 2 diabetes, regardless of the presence of atherosclerotic cardiovascular disease, including hospitalization not directly attributed to cardiac, kidney, or metabolic causes, meaning that the effect of dapagliflozin goes over the, let's say, the benefit we know, and is able to counteract, significantly reduce the risk for hospitalization for any cause in people with diabetes. But of course, The most interesting, there are more and more interesting data. First of all, already declared there was a signals that DAPA can reduce the risk for kidney disease. But then you see here that in this data, this trial also emerged the possibility to improve the prognosis for the risk of kidney disease. And so we had this at the beginning, this kind of information coming from the declare. So after a couple of trials, some trials specifically designed come out. One of the most, the first in this setting was DAPA-HF. Why this is intriguing? Because first of all, the primary outcome was the effect in reducing the risk for heart failure in people with reduced ejection fraction, both with or without diabetes. So were also people without diabetes, and you know the outcome, the trials was successful, and also was not only successful in reducing the worsening of a heart failure event, but also to reduce cardiovascular death. And this effect was independent by the presence of not of diabetes. So dapagliflozin works in people with reduced ejection fraction with or without diabetes. And more recently, another trial was very important and published showing that DAPA works also in another very important setting, which is the heart failure with the preserved ejection fraction. Why this is very relevant? Because the majority of the people with diabetes suffer for a heart failure with preserved ejection fraction. So to show that again, in both diabetes and non-diabetes, that DAPA can reduce the risk for heart failure in this population is very, very relevant and complete the scenario of the effect of dapagliflozin on the risk of heart failure, not only in people with diabetes, but also in people without diabetes. And finally, we had a specific trial also looking at the effect of DAPA on kidney. And this is just the summary of DAPA-CKD. You see that there was a very significant reduction, almost 40% reduction for the primary composite endpoint, sustained decline in GFR, ESKD, renal OCB death, meaning, and then you see you can see the summary of this trial. In other words, DAPA is also very effective in facing the risk for kidney disease. But when we speak about the risk for complications related to hyperglycemia, I introduced the concept that glycemia is very important for the prevention of complications, not only macro, but also macrovascular complications. We have a well-known phenomenon named legacy effect of metabolic memory of glycemia, which means, in other words, that what happens at the beginning of the diabetes, just after the diagnosis of diabetes, the high level of hyperglycemia can impact on the future risk for complications. So this is an effect which can last even for 30 years, as was coming out from the DCCT edict. And particularly, we had evidence, not only, as I told you, from the DCCT edict, but also from UK PDS. So the message is that what you do at the beginning is very important for the future, meaning that you need really to control in a very intensive way glycemia at the beginning of the disease if you want to avoid the appearance of the legacy effect in long term on complications. We were wondering, but all this evidence was coming before the possibility of having in the treatment an SGLT2. And we were wondering, does an SGLT2 attenuate the legacy effect of hyperglycemia? And we had the possibility to use a huge database in Italy, which is the MD Annals, which means more than 500,000 people followed for almost 20 years. You see here a synthesis of the database. And we were able to show, and this paper, you can find this in press in the Lancet, but it's already available online. You see that we were dividing this population and examining the effect, the persistence of legacy effect and the effect of an SGLT2 when the SGLT2 was introduced in the therapy within 1 year from the diagnosis, 2 years from diagnosis, or 3 years from the diagnosis. And you see that the outcome was a composite outcome of all the major cardiovascular events. And we were able to confirm, first of all, that the legacy effect in our, let's say, in our database exists. You see here that there was really a legacy, a metabolic memory related to the levels of A1C for the risk of complications. But what was really relevant to see is that if you introduce an SGLT2 within 2 years from the diagnosis, you stop the legacy effect of hyperglycemia. Meaning that even in people who are remaining with high level of A1C, if you introduce an SGLT2 within 2 years from the diagnosis, you can stop, you can avoid the appearance of the legacy effect of hyperglycemia. On the other hand, so this finding clearly advocates a wider, particularly an earlier usage for SGLT2 inhibitors. And in this effect, we have this also in this line about the efficacy of SGLT2, particularly in combination with the metformin, is coming out with this article just published. You see that this was online in July in Lancet Diabetes and Endocrinology, which is a real-life study able to show that when an SGLT2 is compared to added to metformin and compared to the BP4 inhibitor, sulfonylureas, or GLP-1 receptor agonist, you see that SGLT works very well in reducing the risk for MACE. In other words, in significantly reducing the risk for cardiovascular complication compared to sulfonylureas and the BP4 inhibitor. So, an early use of SGLT2 in combination with the metformin is in the real life accompanied by a huge effect in preventing cardiovascular events. You know, our colleague, just introduction, told us about the ADASD algorithm, where it is suggested to use an SGLT2 when there is high risk for heart failure or kidney disease. But you know that in this algorithm, metformin is always at the first step. I was involved in the development of the European Society of Cardiology guidelines in 2019, where we suggested that in people at high risk for cardiovascular disease or with a previous cardiovascular event, to start immediately with an SGLT2 inhibitor could be preferable. Of course, this created a lot of debate at that time. And when some members of both panels were put together to discuss, they went out with this statement, published again in Lancet, the This discrepancy is tagged as not great as it sounds, considering that most people with type 2 diabetes rapidly progress to requiring combination therapy. It's true. In clinical practice, we know that we start with one drug, but then quite soon you need to add something else. So our answer, what I mean, we were commenting this publication saying, so we believe that the only approach encompassing all the available knowledge for newly diagnosed people with type 2 diabetes is the combination therapy from the beginning. If in short time you need a combination, why do not start immediately? And this is why, if you look at the possibility, what is in this algorithm, of course, it is relevant, the aspect of preventing cardiovascular disease and kidney disease. But on the other side, you have also the need for glycemic control. And in our opinion, the combination is the best way to face the problem of cardiovascular disease and glycemic control in people with diabetes. The two situations very often, they go hand to hand. And so as we published, suggested that the only way is to merge the glucocentric and the cardiocentric view of type 2 diabetes treatment, starting using as soon as possible a combination. So in conclusion, I think that we have strong evidence that when you have the presence of kidney disease, cardiovascular disease, heart failure, there is no doubt you need a dapagliflozin. But also for glycemic control, this is a good choice. But clearly, it's important to screen because an early introduction, according to our data in the Lancet, can help to avoid the legacy effect of hyperglycemia on the long-term risk for complications. But also the glycemic control today is more complex because I told you means a more comprehensive approach to control of glycemia. And when you use metformin plus dapagliflozin, you also have the chance to avoid the appearance of the legacy of hyperglycemia. So in my opinion, there is no doubt that, and this will be, I can anticipate, will be really introduced in the new IDF guidelines, which I'm sharing in the development, the concept that starting with and using as soon as possible, if starting is not possible, is the best choice for our patients to guarantee a life free of complications, particularly cardiovascular and kidney complications. Thank you very much.
Thank you, Professor Antonio. That was an excellent deliberation on dapagliflozin. You told us the various aspects of how SGLT2 are really working in diabetic patients. Now we will move on to our discussions with Professor Antonio and our nephrologist, Dr. Dinakaran. To start with, Professor, I would like to ask you now, you showed very beautifully the Lancet article, which shows the attenuation phenomena of legacy. Now, if you have shown so much data, you have shown how at different levels in hyperglycemia, DAPA is acting, plus the attenuation phenomena. So why today in current diabetic practice, why shouldn't the first drug be, say, DAPA? And what hinders us from really still waiting for the people to tell us that, no, you wait to start with DPP4 and, why shouldn't we now straight away swap to DAPA as a first choice in diabetic patients with all this data you have shown?
Yes, according to the data, there is because you know that the algorithm and also the guideline are suggesting to start a DAPA or an SGLT2 inhibitor in presence of a cardiovascular risk or heart failure risk or kidney disease risk. Our data are stressing that this is something that can be over, meaning it's important, of course, the appearance of a complication is related also to other factors, not only to hyperglycemia. But the legacy effect of hyperglycemia is very well established phenomenon. And if you are unable to better control the glycemia at the diagnosis, and this is very often happens, you must introduce as early as possible dapagliflozin, for example, in order to avoid the appearance of the legacy effect. So not only because, of course, DAPA can help together with the metformin to decrease glycemia much better than only one drug, but you have an extra benefit cutting the appearance of the legacy effect of hyperglycemia. I go on, I have to be honest. I think, but of course, this is my personal opinion, that you can even start with the 3 drugs, because you just told us, but what about the DPP4 inhibitors? But there is, first of all, maybe when you can have an extra, let's say, extra effect on lowering glucose. But do not forget that the only drugs for which the beta cell protection has been shown is for DPP4 inhibitors. Now you know the verified study and so on. So the paradox, in my opinion, is that if you start with the triple combination, introducing not only metformin, DAPA, but also DPP4 inhibitors, you can have a better outcome also because you can protect better the beta cells. On the other hand, and I will finish, my colleague, a nephrologist, you are a cardiologist. Are you treating hypertension with one drug today? I don't think so. No, usually you are using combination for treating hypertension because the idea is to tackle different mechanisms. So why diabetes, in which we think there are at least 8 pathways involved in this disease, we have to think that one drug can work on all the 8 at the same time.
Thank you, Dr. Antonio. We'll move on to Dr. Dinakaran. Dr. Dinakaran, in
Yes.
your practice, if you have a patient of diabetes with CKD today, okay,
Yes.
now we know KDIGO's recommendation is, should SGLT2 inhibitors be your first choice as an anti-diabetic when patient has already developed? And does the stage of CKD matter when you're talking about using this SGLT2? So I would like to have your comments on this.
Yeah, the present-day consensus, both from KDIGO, and there was a consensus statement from ADA and KDIGO, which was published in November 22 in ISN, International Society of Nephrology Journal. They have categorically stated that even with CKD in diabetics, we can use SGLT2 inhibitors safely with a GFR above 30 ml per minute. That's a safety. But further studies have thrown more light, and they now say that you can go up to even 20 ml eGFR for using SGLT2 inhibitors. Why this difference? Initial studies with SGLT2 inhibitors showed that the glucose reduction through the renal glucosuric mechanism was possible at GFR above 45 ml per minute. But further studies highlighting cardiorenal protection have shown that the cardiorenal protection is offered even for people with lower GFR. Even though it may not have much impact on the glycemia control, it has a tremendous impact on the reducing the cardiovascular morbidity and mortality, renal morbidity and mortality. So now it has been said that you can use it up to a GFR of 20 ml, above 20 ml GFR. You are justified in using SGLT2 inhibitors along with metformin or along with other drugs that particular individual requires for control of blood sugar and for other comorbid conditions. It can be used as a first-line drug. It can be used in combination with metformin, or it can be used in combination with other drugs that are required in this clinical scenario. And most of these cardiorenal outcomes with SGLT2 inhibitors were studied by using SGLT2 inhibitors over and above RAS blockade with ACE or ARB. So already they were protected to some extent against cardiorenal outcomes with RAS blockade. Over and above, the SGLT2 inhibitors were able to show additional benefit. That is the real advantage of SGLT2 inhibitors in treating people with diabetes mellitus and CKD. I think I have answered the question.
Yeah, absolutely. Thank you. Professor, back to you. There are two questions actually. What about comparison of DAPA or SGL2 versus GLP analogs? Because GLP analogs, GLP-1 analogs also, have that weight reduction, all those components which you stressed. So how would you compare GLP analogs with DAPA? Dr. Antonio?
For the patients, first of all, one is injectable and the one is a pill. So this makes the difference. Not all patients easily accept to have injection. But I believe that they are completely different. First of all, for the mechanism of action, because one is anyhow depending from insulin to work. The GLP-1, they need insulin. The SGLT2 inhibitors, they do not need insulin. It's the only kind of drug which can treat diabetes, not through insulin in any way, but independently. So they are completely different. In my opinion, in the future, probably when we will start to have the trials which are ongoing, the results, probably I believe that a combination between the two could be a right solution, because you tackle different mechanisms of cardiovascular events. But for example, if you know that heart failure, the SGLT2 inhibitors are particularly effective, GLP-1 probably are not. There are some meta-analyses, but you need to pull all together the data to see an effect. So in any trial, this effect on heart failure is coming out using a GLP-1. Moreover, the protection of the kidney is not so well established. You have a reduction of microalbuminuria or albuminuria, but there is no clear effect in the protecting. My colleague and the nephrologist can, let's say, confirm that if you see just a reduction of albuminuria, does not mean that you really protect, because you have to see also the effect on GFR. So at the end of the day, I think that using an SGLT2, you have a more comprehensive protection compared to the GLP-1 agonist. If you want to get more weight reduction, yes, GLP-1 works better. This is well known and is nothing that is a surprise.
Okay, thank you. Very good. Dr. Dinakaran, when you are using, say, DAPA in your CKD patients, especially 2, 3, 4 stage, what are the likely side effects? What are you look? Is the UTI incidence more? What are you going to look at in those CKD patients more than when there's no CKD?
See, when the CKD is there, stage 3 is actually the most vulnerable stage of CKD, stage 3B, we specifically mentioned. That is with a GFR between 30 to 44 ml per minute. That is the stage of CKD where the cardiovascular morbidity, mortality, everything takes a fast turn. At that stage, there are definite evidences, because as I said earlier, you can use up to a GFR of 20 ml per minute. So it takes care of the most vulnerable stage of CKD, stage 3B or 3A, and so it is useful. That is as far as the beneficial aspect is concerned. But you were talking about the side effects or problems that can come with regard to SGLT2, especially in the presence of a little advanced CKD. The issues are, there is a risk for genital infections, usually superficial infections. And they are overcome by definitely advising the patients about their personal hygiene. That's the most important thing. Once they take care of that, this sort of an infection is not that high, not that disturbing. The second aspect is the dehydration or hypovolemia. If for some reason the patient is already hypovolemic, maybe due to the use of diuretic or due to dietary water and salt restriction because of CKD, then we may have to be a little careful about the use of SGLT2 inhibitors. Because in the presence of hypovolemia, the glucuretic and the natriuretic effect of SGLT2 inhibitors can make things a little worse. There can be two things. One, there can be an acute increase in the creatinine or fall in eGFR. Two, it can precipitate cardiac and renal events also, because it acts on severe hypovolemia and further potentiates that and can lead to problems. So again, here a word of caution is ensure the correct hydration status of these patients when you are putting them on SGLT2 in addition to RAS blockade or diuretics, or try to moderate the dose of diuretics and then add SGLT2 inhibitors. That's how we view at it. There is another situation called the sick day protocol. A diabetic with CKD, suppose he goes in for a complication or is going to face a surgery. If he is severely dehydrated, has some surgery procedure awaiting. In these times, like some of the drugs which should be avoided, maybe NSAIDs, contrast agents, SGLT2 inhibitors, metformin, there is a general caution that is required in the use of these agents. I think these are the situations where we'll have to be a little cautious in using and continuing SGLT2 inhibitors.
Thank you very much. Professor, back to you. A few questions on weight. Suppose you have a patient who is, of course, obese. We know it is going to help. The DAPA is going to help. Suppose somebody is very 55, 60. Would you still think of starting DAPA in this patient? Because sometimes they really lose weight. So what is your position on starting DAPA in a person who is, say, thin, or of course, obese will start? About the other side of weight.
If I got it, because weight is something that is an extra benefit, but I don't think it is the first driver to use an SGLT2. So honestly, I think that there are so many other aspects that for which you must use an SGLT2, that the weight is what I mean is something that you get, but you never can. In my opinion, I never will use an SGLT2 in order to lose weight. It is why you also can easily use in the lean people, because of course you get the advantage of the complications in controlled glycemia. And I have to say that it's really pity that the DAPA is not anymore used also in type 1 diabetes. You know that this was approved in Europe for the use, and the company who is selling in Europe the dapagliflozin decided to stop this indication, because of course at the horizon was a huge important new market, sorry if I have to say this, for heart failure in people without diabetes. And because in type 1 there was some risk for ketoacidosis, the company decided to skip this indication for type 1 diabetes. And I know that there is a lot of concern in the association of type 1 diabetes, because look, this is also a real problem. Type 1 diabetes is also a high risk for cardiovascular and renal complications. Why they cannot use a drug which is well established in protecting these organs? Because there is no there is an indication, but what I mean, there is not anymore. It was approved, but the company decided to cancel this, to risk something for in the view of the new markets.
Okay, and somebody from the audience has asked the question: can we give DAPA twice a day with the meal? Because whatever glycemia comes with the meal can be sort of negated if we give with meals twice a day. Somebody from the audience has asked, instead of once a day. Is there such a thing to do?
Why? Honestly, it works once a day. It's very well known that the half-life is so a lot longer to guarantee that once a day works on both meals. So there is no need.
We have to use only once a day. Dr. Dinakaran, if you start SGLT2 in a CKD patient, what are the parameters? What are you going to look at? Creatinine, eGFR, or what are both the values where you would reduce, stop, or wait after you start SGLT2 in a patient with, say, mild CKD? So what is your creatinine value? What is your eGFR? And when would you reduce the dose? When would you stop? What is your current concept about CKD and what happens with the side effect?
Actually, in CKD, there is no serious dose modifications required for SGLT2 inhibitors. It varies between the different drugs. For DAPA, we can use 10 milligram once a day, whatever be the GFR. That is up to a GFR of 20 ml. That may roughly correspond to a creatinine value of 5 or 5.5 milligrams of creatinine. If somebody has been started on SGLT2 with a GFR of, say, 30 ml, and during treatment over a period of 1 year or so, if there is a further reduction in eGFR, you can continue SGLT2 inhibitor if there is no steep fall in eGFR. The acute or steep rise in creatinine can happen in a small percentage of patients on starting them on SGLT2 inhibitors. Usually this happens by about 3rd to 4th week, but it gets plateaued after, say, 3 to 4 months. This is the observation with use of RAS blockade also. So those drugs which interfere with the glomerular filtration and reduce the increased glomerular filtration initially may cause a fall in eGFR. But this actually turns out to be a protective mechanism because by reducing the initial elevation of the glomerular filtration rate, it helps to reduce the long-term damage in the glomeruli and in the tubules. So it's not an absolute contraindication, but how much the creatinine rises, how much the eGFR falls. Are there any other agents that are working in this patient which conspire to introduce this complication? Then probably we may have to decide on which drug to withdraw to overcome this problem. Otherwise, categorically, GFR to start with SGLT2, current view recommendation is above a GFR of 20 ml per minute, you can start even in CKD with diabetes. If you have already started GFR falls, you can continue. If there is an acute elevation initially, try to look for other causes that would have caused this acute elevation of creatinine. Try to withdraw that or adjust the dose. As I already said, avoid dehydration. Don't use it in the presence of sepsis. Don't use it in the presence of severe urinary tract pre-existing infections. If there are wound ulcers, foot ulcers, etc., you will have to be cautious. In addition to the level of creatinine or eGFR.
And one more question from the audience for you, Dr. Dinakaran. Suppose somebody's creat is 3+, and you want to start HCl2 with metformin. Is there any sort of a difference in the renal toxicity?
For metformin, the guideline is that you don't use it below a GFR of 30 ml per minute. So, for SGLT2 alone, I can go up to a GFR of 20 ml per minute. A creatinine of 3+ roughly corresponds to an eGFR of 30 ml. So, my advice will be, if you already have a creatinine above 3, we may have to forego metformin and then continue with SGLT2.
Okay, thank you. Professor,
you are not audible. Yes.
How are you making use of this data for DAPA in preserved EF? Should it be the first choice with diabetics or non-diabetics with the data which has already been shown?
I think you are the right person to answer, but yeah, of course.
We have started using quite a bit in with preserved EF. In fact, that is perhaps the data shows that perhaps that is the only one after Candisata. That was the only thing which she has really shown to help people. Though we know such a spectrum is so different, but in our practices we have started using quite a bit. But especially in diabetics with preserved heart failure, I think that is the subset where every patient should, at least we should start this, because all the diabetic angle of, DAPA you have shown, and preserved heart is only one data, whatever data we have shown. So at least diabetics with preserved heart failure, all our patients are at least 10 milligrams of DAPA. So that is what we have started using routinely in our clinical practices. So just your comments on that.
No, I agree with you, of course, with your point, but I think that the problem of heart failure is very serious in diabetes. We had some surveys in some countries in Europe, and you find out that at the diagnosis, more than 30% of the people, they have already signaled for heart failure. So to start very early, and you know much better than me, that the most frequent is heart failure with the preserved ejection fraction in diabetes. And you also know how difficult is the diagnosis, even to suspect something like this. This is why, particularly to the new ADA consensus, I think that an early screening, at least in people with diabetes at high risk. What I mean, clearly you cannot screen all the million of people with diabetes. But if you have people with diabetes, hypertension, well, not controlled hypertension, probably there is no doubt that you have to screen for heart failure in these people, even there are no symptoms that can indicate this. About the treatment, I agree, but I also to say that I'm very happy that I'm a diabetologist, And if I suspect that there is a heart failure, I can screen, but then this is your job. I believe that is really the job of a cardiologist. We cannot confuse the rules in this.
Okay. So, Dinakaran, what about dialysis? Why can't we give DAPA or even ARNI for that matter? Now there's a data from China on ARNI there's a lot of data on dialysis and or in-stage CKD and ARNI. But with SGL2, if you're going to dialyze anyway, what's the harm of giving SGL2 or ARNI in such patients?
See, straight away I can say that somebody has reached stage 5 dialysis requiring CKD. There is nothing much to protect. I think for the cardio protection, we have other drugs that are going to be useful. Hyperglycemia, if it persists, even in a patient who's on dialysis, he will have a very brittle diabetes. Sugar will fluctuate on the day of dialysis, and the day when he is not on dialysis, there will be wide fluctuations. So it has to be monitored and treatment has to be given. And in 80% of these patients, we have to manage them with short-acting insulins. The oral hypoglycemic agents in general have got a very limited role. And there are very few studies of SGLT2 inhibitors in patients on dialysis. But you go one step ahead, post-renal transplant. Now there are a few reports saying that SGLT2 inhibitors will be helpful in controlling diabetes, recurrence of diabetic changes in the transplanted kidney, and even in restricting the occurrence of de novo post-transplant diabetes mellitus. So it's not that it is not useful, but a dialysis patient is a big bet, is a wrong bet, probably to rely on a drug like SGLT2 inhibitors. That's my opinion.
Okay. Professor, one thing which we always comment upon is the incidence of how DAPA, actually there are data which says that DAPA prevents the incidence of new onset atrial fibrillation in heart failure patients. The good data. So even that point also has to be considered. So you just comment on that.
I think that the story is related mainly to the first up. The first data were coming from DAPA for DECLARE. There was a first signal because many of the patients in the trial were almost in primary prevention. They were high risk, but primary prevention. The effect was evident in both subgroups in terms of prevention of heart failure. So clearly, there was something misunderstanding, in my opinion, at the beginning of the story, because we were speaking mainly about hospitalization for heart failure, which is a very advanced situation. Why clearly now we have also data that you prevent the appearance of heart failure, which is something else. You do not need to be hospitalized to have the diagnosis of heart failure. You do not need an acute event. So, in principle, I do not see why today you cannot use an SGLT2 as first choice, even also in combination with the metformin, because you really, let's say, you merge the cardio and glucocentric approach, because it's a very good hypoglycemic agent, a very well-established protector for cardiovascular disease and kidney disease. So why not?
Okay. Dr. Dinakaran, what about, there is something from the audience that, the correction or prevention of anemia in CKD, has DAPA anything to do with that, or there is no role for DAPA in looking at anemia in CKD? That's what somebody has asked.
No, actually, a sub-study of Credence, which used canagliflozin, and then later on, some studies with DAPA, they showed that the anemia of diabetic CKD improved when they were put on SGLT2 inhibitors. So there is some effect on erythropoiesis by SGLT2 inhibitors. Some of the proposed mechanisms are, one, by reducing the cortical concentration of glucose, because these drugs facilitate tubular excretion, it somehow influences the hypoxia-sensitive nature of the cortex, helps in forming more erythropoietin and correcting anemia. That's one view. It reduces the it improves the sensitivity of the hypoxia sensing factors in the kidney, which is responsible for stimulating the erythropoietin levels. And the other factors that interfere with anemia correction is the high levels of hepcidin and inflammation-related high levels of ferritin. There have been reports that the SGLT2 inhibitors prevent this rise in hepcidin and also reduce the inflammatory action and bring down the ferritin also. So these are the views or studies that are available showing that SGLT2 inhibitors will be helpful to some extent in improving the anemia of CKD in a diabetic. While we are talking about this, beyond cardiorenal protection, there are certain other aspects, especially in nephrology, where they have shown that these group of drugs, SGLT2Is, have a benefit. We have seen that obviously in obesity with glomerular sclerosis and obese people presenting with gross proteinuria, SGLT2 inhibitors help. One, by reducing the weight and also by reducing the protein excretion. I have practically seen this in some of my patients. Another situation is IgA nephropathy, where a lot of studies have been done recently, and there is evidence to show that SGLT2 inhibitors have got a role to play in reducing the proteinuria of IgA nephropathy, which is a condition which has massive proteinuria and a tendency to progressive CKD. SGLT2 inhibitors are today one of the major lines of therapy. Some other areas where they have shown some fringe benefits are in hyponatremia management, magnesia, hypomagnesemia management, and post-transplant patients also. So the expanded indications is there with more and more studies coming with reference to different aspects of SGLT2 therapy.
Thank you. Professor, the final question to you, difficult as usual. Is there anything to choose between EMPA and DAPA? Is there anything to choose between EMPA and DAPA?
I have to be honest. Okay, let's see. There is only one difference in terms of evidence. I have to be honest. I think that this is due to the kind of studies they perform. Because you see, in the EMPA-REC, all the people were at high risk, were having a previous cardiovascular events, while in the DECLARE, 50%, more than 50% were in primary prevention. We do not have this data for empagliflozin, meaning we don't know in primary prevention if it works or not. I have to be honest, I believe that it works. But if you just want to look at the evidence, this evidence is not, at least not yet available.
Okay. Thank you, Professor. I think I thank Professor Antonio and Dr. Dinakaran. We had an excellent discussion. I think it's time to stop all good discussions. Over to you, Dr. Rajeshri.
Yes, sir. Thank you so much for such an interactive session. So I have two questions in mind. So from an audience, actually, Dr. Sharma has asked, should we, or use SGLT2 inhibitors in patients with T2DM and heart failure who are treated with insulin? So it's to all of the doctors in the panel.
Dr. Dinakaran, CKD and heart failure. What is he asking?
Yes, it can be used because in both these conditions, it is indicated. Only thing you will have to watch the response and watch the role of other drugs that you are using in these patients. So it is these combinations that have to be very judiciously managed. It has a role.
All right. Anything to add from Dr. Antonio?
The expert is just answering.
Okay.
I do not, I have no comments.
Okay. So I have one question only to our cardiologist moderator here. So, what according to you is the practice around SGLT2 in your setting, or if you can say in Indian setting as per you?
Yeah. See, actually now, if you look at the spectrum, I think it's a fascinating drug because you have a large spectrum, heart failure from reduced to preserved. That's number one. You have prevention outcomes in CKD, in CVD, from primary to secondary. So now you have a drug which is working at a different level. Now with the legacy effect just shown, in fact, now there's no reason why in all these spectra, we should not use SGL2 very aggressively. I mean, there's nothing which should prevent us from using it. Just a few words of caution what we have seen in India. The second is the ease of using SGL2. It's easy. You don't have to titrate anything. You don't look at too many things. But yes, you have to explain to them about genital infections. You must give some time and explain to these patients. But otherwise, there is nothing. It's the ease of administration. It's easy from ADHF from the third day to chronic heart failure. You can easily use this drug. And this is from a spectrum in India. And that is what we have found actually in one of the statistical data. And if you see heart failure and all the 4 pillars, cardiologists are still more with ARNI and SGL2, while physicians are first SGL2 and then ARNI. And this is, of course, because of the use of, this is just the data. It is not that one is better over the other, but this is what it is shown. But today, with all this, and now I think, maybe Professor will correct me, but over a period of time, I think we have to get recommendations in diabetes. So type 2 diabetes, perhaps recommendations might come and change, that our algorithm of using anti-diabetic drugs may change, and perhaps we may have SGL2 as the first drug of choice. We don't know, it's still time, but we're still waiting for those recommendations.
Yes. So eagerly looking forward to that. Thank you so much, Dr. Sunil, for moderating the session today. Thank you, Dr. Antonio, to be here with us today. And thank you, Dr. Dinakaran, to answer all the questions as per your practice. So it has been such an honor to be a part of this wonderful event. On behalf of my organization, I would like to extend my heartfelt gratitude to our esteemed speakers, Dr. Antonio, Dr. Sunil, and Dr. Dinakaran. Thank you, sir, for taking time on the weekend and giving your valuable feedback, which will help us in future for sure. Sincere thanks to my team who had handled the event throughout, and thank you one and all. Good night. Thank you.